Sorry I couldn't be there in person. Hopefully technology will work for me because, I often have trouble with technology, so it seems to be working. So I will be talking today about some of the newer treatments for polycythemia vera that are coming up in the pipeline. So I guess I will start with these questions. What are the goals of treatment for polycythemia vera? And overall, we have a few goals. Of course, the first one for everyone is to improve survival. We want to prevent disease progression to myelofibrosis and MPN blast phase. And we want to decrease the incidence of events, so thrombotic and hemorrhagic events. And we want to alleviate systemic symptoms. So the treatments that we currently have and we're currently using as standard of care do some of these things. And some of them do more than others, and some of them maybe do all of them, depending on how far we take, like if we talk about something like transplant. But we are looking for new treatments that, again, ideally would be able to do all of these things. But we will take whatever we can get, right? If we can get something that will alleviate some of the symptoms or prevent the risk of thrombotic and hemorrhagic events while alleviating symptoms, anything of that matter will certainly be helpful. And I just wanted to mention, so some of the current drugs that we have that are currently in use, such as interferon or ruxolitinib, while they are not new drugs and they've been on the market and heavily used for a long time now, there are ongoing clinical trials using these drugs, and we keep learning new information about their effectiveness and their effects on potential on disease modification and overall survival improvement. I will not be talking about that because I think you already heard about this. I will actually be talking about the new drugs that are not yet approved. So these are some of the drugs that I will talk about today. So rusfertide, which is a drug being developed by Protagonist Therapeutics, divesiran, Silence Therapeutics, sapablursen by Ionis, and all three of these drugs are affecting the hepcidin iron pathway, and I will spend the first few minutes talking about that pathway and trying to explain exactly why it's important and how we're using it to treat polycythemia vera. And then I'll spend just a couple of slides talking about givinostat, which is a completely different drug. So what is the main problem in polycythemia vera? I think everybody here knows that because many of you, unfortunately, haven't to deal with it directly or indirectly. But the main problem is that we're making too much blood. The bone marrow is making too much blood. And what is the main form of treatment in polycythemia vera? We might get different answers from different people, but I think this is one of the treatments that most patients get at some point in their polycythemia vera career. And what could be potential problems with phlebotomies? I mean, some of these answers, of course, are obvious to everyone here. But some of the other things I think about are listed here. So hematocrit level is not always maintained at goal. It goes up and down. So we wait for it to go up and then we remove the blood, which gets it better controlled. And we know that for many patients, especially in the community, it's often difficult to maintain these numbers at goal because it requires frequent visits and a lot of monitoring. Also, phlebotomies can worsen iron deficiencies. Iron deficiency, we know that. We know many patients have iron deficiency, and phlebotomies make it worse. And that can also result in worsening of the symptoms, such as difficulties in concentrating, such as brain fog, itching, fatigue, and some of the others. And then some people are not able to tolerate phlebotomies, either physically or emotionally. And some people have a lot of anxiety related to coming in and having that procedure done. Some people faint when they have phlebotomies, and some people just have, they don't have great veins, and it makes it very difficult for them to undergo this procedure. So what can we do to avoid phlebotomies for some patients? And can we avoid phlebotomies for some patients? So of course we can. So cytoreductive therapies that we currently use do that. For some patients, phlebotomies are completely eliminated, and for some patients, the number goes down, but they may still need it. And then the new drugs that affect the hepcidin pathway basically can replace the need for phlebotomies. And I will talk now about how exactly that works in our body. So I'm showing this complex diagram just to sort of give an example of how important and complicated this pathway is in the body. So it's the hepcidin iron pathway in the regulation of red blood cell production in the bone marrow. So hepcidin is a hormone. It's made in the liver, and then it regulates the uptake of iron from enterocytes, so from the cells in the intestines that absorb the iron, and also release of iron from macrophages and some of the other cells that store iron. And then when this iron is available, it's in the blood. It's then available in the bone marrow for production of red blood cells. And then production of red blood cells, of course, is regulated by many other categories of but different mechanisms. And one of them is EPO, erythropoietin, that is made by the kidneys. And then iron itself can regulate production of hepcidin in the liver as well as inflammation and many other processes. So a very complex process, but I think we can utilize it for treatment of PV in a actually pretty simple way. So this is a diagram of how we think that the idea of manipulating the hepcidin way can work. So in the setting of low hepcidin, as is shown in this picture here, iron is absorbed by the cells, by the intestinal cells, for example, and is freely flowing into the plasma where it's available for blood production. On the other hand, when hepcidin levels are high, hepcidin binds to ferroportin. Ferroportin is a receptor on the surface of the cells that binds hepcidin. Ferroportin is then internalized, and iron cannot come out of the cell. So it accumulates in these iron exporting cells, such as macrophages, hepatocytes. Hepatocytes are the liver cells, and enterocytes, which again are the intestinal cells. So instead of iron freely flowing into the plasma, it is stuck in these cells um, and is not available in the body for blood cell production. And so this is how this pathway is being utilized to potentially treat polycythemia vera by reducing the amount of iron that is available to the bone marrow for red blood cell production. Now, all cells in our body need iron for their function, but majority of iron goes to the bone marrow to make the red blood cells. So by restricting the amount of iron that's available in the bone marrow to for red blood cell production, we can control the hematocrit. However, the minute amount of iron that is needed for other cellular function is still there. And so it is still available for all the other processes that cells need to do. And we can do, and this is being done in a few different ways. So one is using a hepcidin mimetic. This is a drug called rusfertide. So basically it's replacing hepcidin in the body. And then there are other approaches where we are using different ways of increasing endogenous hepcidin production. So making the body produce more hepcidin. And these two compounds, divesiran and sopaborsen, which are both of these drugs are currently in phase 1/2 trials. I will talk about the data for divesiran because that was presented at ASH, and we're still waiting for the data on the other drug. And then there are other companies that are also looking at this pathway. For example, Disc Medicine and Agios and some of the others. And these are still in preclinical development. But so there potentially could be other clinical trials coming up using this pathway. So this is the mechanism of action of rusfertide in PV. So I'll probably be repeating some of the things I just said. But basically, rusfertide, hepcidin mimetic, in polycythemia vera, ferroportin is open because hepcidin levels are low. And so iron freely is flowing into the plasma. It's freely available for red blood cell production. And we know in polycythemia vera that the bone marrow is like, it's basically all it wants to do is to make red blood cells. And so it's free to make as many red blood cells as it wants. On the other hand, in the presence of hepcidin mimetic, rusfertide, the ferroportin is closed and iron is in the form of ferritin is stuck in the cells, in macrophages and other cells. And so the production of red blood cells is still happening, but it's much better controlled, and we can titrate it to the level where we want it to be. And so this idea led to this phase 2 study of using rusfertide in patients with polycythemia vera. So the study had the eligibility were pretty simple. Patients had to have diagnosis of polycythemia vera, and they needed to have a pretty heavy phlebotomy dependency. So to be able to show that this is something that works to decrease the number of phlebotomies. So patients needed to have at least 3 phlebotomies in 6 months prior to enrollment. And then the dose of rusfertide was titrated for each patient to get them to the to controlled hematocrit numbers that we wanted to see. And so this study had 3 parts. The first part was the dose finding study, where the dose of rusfertide was titrated to the effective dose. Part 2 was blinded randomized withdrawal. So patients were randomized to either continue on their last respective dose, last effective dose, or to get a placebo. And the part 3 was an open label extension. So the results of the phase 2 studies are available, and we will go over them now. And I think this diagram is actually the most powerful one of them all. And it demonstrates how effective this drug is. So patients on the study included both patients that were just getting phlebotomies as treatment for PV, or that were getting phlebotomies in addition to cytoreductive therapy. So they were on ruxolitinib, for example, but still needed the required number of phlebotomies, and so they were eligible for the study, which was basically added on to whatever therapy they were on. So each red dot here represents a phlebotomy event. As you can see, prior to starting on this treatment, there were lots of phlebotomy events, and once patients started on treatment, the number of phlebotomy events significantly decreased. And that was very impressive to see. And this is just showing this same phenomena, but in a different way. So we're showing here the number of responders versus not responders in both groups, those patients that were treated with placebo, those patients that were treated with rusfertide. And basically, as you can see, the number of responders significantly higher in those patients that were treated with rusfertide. And responder here was defined as someone who did not receive a phlebotomy, but also did not need a phlebotomy, were not eligible for phlebotomy, and also completed the full 12 weeks of treatment. And this is why, the difference is not even higher than what is shown here. But either way, this is a highly significant efficacy between the two groups. And then this graph is just showing, I think, nicely that those patients that are treated with rusfertide, hematocrit is controlled, and that control is sustained. As you can see, when patients went on placebo briefly, the numbers increased, and then once they went back on the study drug, the numbers went down. What's interesting also is that, as I mentioned before, many patients with PV tend to be iron deficient, and since these patients were heavily phlebotomy dependent, they were definitely very iron deficient, as you can see here at the baseline. And when they were treated with rusfertide, ferritin levels increased and normalized. And interestingly, when they were receiving placebo, the numbers went down and then went back up as they went on study drug. And so what it's showing then is that not only are the hematocrit numbers controlled and the number of phlebotomies is decreased, basically eliminated, in addition, there's a distribution of iron that's potentially making these patients less iron deficient. So this is a figure that showed some of the potential symptom benefits that was seen in the study. So this is from the first part of the study, so this is not the randomized data. But what is shown here is that for those patients with PV that had significant, so moderate or severe symptoms, there was a significant improvement. So in categories such as fatigue, or satiety, night sweats, problems with concentration, inactivity, and itching. So some of the main symptoms of polycythemia vera that I'm sure many of you are well aware of, there was, for those patients that had significant debility from these symptoms, there was improvement. And this is just showing, this was shown at last European Hematology Association, in that over a longer period of time, as these patients remain on study for over 3 years at that point, that the control of hematocrit remains. Interestingly, white blood cell count numbers did not really change significantly over this time. And there's an slight increase in platelets initially. So about 20% increase in platelets, and then they stabilize. And that did not appear to have any clinical significance in terms of patients' symptoms. And this drug was well tolerated. So the most significant treatment emergent adverse events, so basically the most significant events that patient reported on study were injection site reactions. So this drug is given as a subcutaneous injection once a week, and patients were self-administering the drug. So many patients had injection site reactions, but interestingly, these were usually self-limited, and over time, the severity of injection site reactions went down for each patient, and all patients were able to remain on study and deal with this reaction, but also for most patients, it just went away. And some of the other things were fatigue, some joint pains, dizziness, and nausea, but things that most likely were related actually to the disease itself and not to the drug. And so phase 3 for this study is ongoing right now. This is where patients from the beginning are randomized to get placebo or rusfertide. The study finished enrolling. We're expecting to get results from this phase 3 study, I think probably over the summer. I'm hoping, and I think this will really give us a lot more information about this drug and the future for this drug. So very excited to see the results for the phase 3. Now, I will talk a little bit also about another drug that is using this pathway, but doing it in a very different way. So here we're using RNA technology to manipulate hepcidin production by the liver. So instead of actually adding hepcidin, we're making the body make more hepcidin. So this is a pathway that is responsible for increasing production of hepcidin protein eventually. And there's a negative regulator of this pathway called TMPRSS6. And so this RNA technology, two slightly different ones, but basically both using RNA molecules, inhibit the negative regulator of hepcidin production, and therefore increases the endogenous, so the actual production of hepcidin by the body. And I think this is a very interesting way of doing this. So the results of the Silence Therapeutic divesiran study presented at ASH this year. But this is basically the idea. It's just a different picture showing this pathway. And again, this is using RNA technology. So it's a small interfering RNA that will bind up this negative regulator of this pathway called TMPRSS6, therefore removing this negative regulator, and this results in increased production of hepcidin by the body. And so this is the phase 1 study, and it had 3 different cohorts of patients using 3 different dosing regimens, 3, 6, and 9 milligrams per kilogram of the drug. And eligibility criteria for the study were very similar to what I described before for the rusfertide study. So basically, patients with PV who are heavily dependent on phlebotomies were the patients that were enrolled in the study. So again, very similar. And so this is a similar diagram that I showed you for rusfertide, where again, each red dot represents a specific phlebotomy event. And again, you can see that these patients had a lot of phlebotomies prior to starting the study drug. And once they started the study drug, the number of phlebotomists significantly went down. What's different about this study drug is that it's, as opposed to once weekly, this one is also a subcutaneous injection, but is given every 6 weeks. And as summarized here, for this patient group, there were 79 phlebotomies total prior to dosing. And then after start of the dosing, there were 5 in treatment period and 2 in follow-up period. So significantly decreased the number of phlebotomies. And also what was interesting here is that because this was a phase 1 study, included patients from all over the world, but also all different patient populations. And so some of these patients had a relatively well-controlled hematocrit at the start of the study, less than 45, and some patients did not. Some patients had hematocrits that were over 50. But for those patients that had controlled hematocrits at less than 45% at baseline, they did not require any phlebotomies on treatment. So also very interesting results. And what is shown here again is that when we look at ferritin as a marker of iron levels and iron deficiency, most patients were iron deficient at baseline. And in all of these cohorts of patients, ferritin levels went up, similarly as what we saw with rusfertide. And this drug was also safe, appeared to be safe and well tolerated, which of course was the main point of this phase 1 study. So the treatment emergent adverse events were seen in most patients, but they were pretty much minor and self-limited. None of them were greater than 2. And again, there were some self-limiting injection site reactions seen in slightly more than half of the patients, and none of them led to discontinuation of the drug. So just to summarize the hepcidin targeting agents, so iron hepcidin pathway seems to be a pretty attractive tool to control erythrocytosis in patients with PV, where we could potentially, for those patients that need it, could replace the need for phlebotomy with one of these drugs. And rusfertide has been shown to be effective in controlling phlebotomy requirements in PV patients, as well as increasing ferritin, as well as a hint of improving symptoms. Results of phase 3 Verify study are eagerly awaited. And I didn't mention this, but long-term extension study called Thrive is continuing. So we'll have long-term safety data with rusfertide. Some of these patients are on at this point for over 4 years. And then actually maybe longer. And then there are different approaches to increase endogenous hepcidin, where inhibition of this negative regulator of hepcidin production that are being explored by Sounds Therapeutic, Ionis Pharmaceuticals, and both agents allow less frequent dosing compared to rusfertide. And then this phase 1 study of the Vesperin shows promising early results. Phase 2 is currently enrolling patients outside of the US, and hopefully we'll start enrolling patients in the United States as well. And then other agents are being explored in preclinical and early clinical development. So we might see more drugs, more drugs using this pathway. And so just a few last minutes, another drug that is being studied in PV, something called givinostat. So it's a class of drug that belongs to group of drugs called HDAC inhibitors, histone deacetylase inhibitors. And so histones are proteins that associate with DNA and help condense it into chromatin. And so what is known is that the high HDAC activity results in compact chromatin and therefore suppresses gene expression, silencing of tumor suppressor gene or apoptotic gene. So when the chromatin is very condensed, then certain genes cannot get transcribed because they're the proteins that need to get to it to allow it to be transcribed and therefore to be expressed and start making the protein are not available. And this class of drug has been shown to have some activity in MPNs, and there's a lot of preclinical data about this class of drugs may be very effective in MPNs, and specifically in PV, but also in other MPNs, as well as in other tumors. And so this is some of the results so far that was published in 2021, and it demonstrated good safety and efficacy in 3 phase 1 or 2 studies in patients with PV. And they tolerated the givinostat treatment, had achieved clinical benefits at the end of the core protocol, and then continued into this long-term multi-center study where patients who were getting benefit remained on the drug. Um, and so the overall response rate for the duration of follow-up at that time was more than 80%. Overall response rate included patients who had complete response, but also patients who had partial response, meaning perhaps they had hematocrit control, but the platelets were still elevated. Um, and then again, importantly, this drug is well tolerated. So these early studies led to the development of the phase 3 trial, which is currently enrolling patients. So these would be patients with high-risk polycythemia vera, and in this trial, we'll randomize patients to givinostat versus hydroxyurea as a first-line therapy. So I think this will be also very exciting to see what happens with the drug, because potentially will offer us other first-line therapy options. I'm just going to mention this for a minute, because in a way, this is something that is being developed myelofibrosis, but something in the past we were looking at for PV and hopefully will be in the future. So TP53 is a very important regulator. It regulates a cell cycle, apoptosis, DNA repair. So it's just very important for many cancers. Um, and we know that p53 expression mutations is at a much higher rate in more advanced MPNs compared to earlier MPNs. Um, and there is a lot of negative regulation of TP53, and many tumor types take advantage of this to decrease the amount of TP53, and that potentially could result in MPN progression. And so this was a study done a while ago by my colleague, Dr. Mascarenhas, was published in 2022. And this is using a drug called idasanutlin, which is an MDM2 inhibitor, which basically works by increasing the level of TP53 in the cells. And what it showed here is that it was effective in achieving hematologic and molecular responses. And this study was done in patients who had polycythemia vera who were previously treated with other agents. It was not one of the issues with the drug was that it was not well tolerated due to a lot of GI toxicity or some GI toxicity. And for various reasons, development of this drug in polycythemia vera was halted. But there is another drug that I'm sure Dr. Mascarenhas is talking about that's being, of course, developed for myelofibrosis right now, called naftamidlin. And so my hope is that someday this group of drugs will make its way back to polycythemia vera, and we will see more studies looking at it in polycythemia vera. So in summary, there are agents that are targeting iron hepcidin pathway are being developed that will control hematocrit and reduce the need for phlebotomies. Hopefully will improve symptoms as well as to reduce the risk of thrombosis long term by allowing more steady state control of hematocrit. Other agents such as givinostat are being investigated for potentially first-line therapy in patients with PV. And in general, MPNs are a very hot area of clinical investigation, and hopefully more drugs on the horizon, and I would have many more drugs to talk about in the near future. Thank you for your attention. I'm happy to take questions.